All right. So welcome to Future Generations University. Here we believe in the power of people working together to transform communities. We offer a master's degree in applied community development using the principle of learning while doing. Individuals from around the world apply methods and tools to create sustainable change within their own communities, which serve as their individual classrooms. The master's program guides students to tackle real-world community challenges in areas such as strengthening local economies, livelihood development, environmental conservation, health, peace building, regenerative agriculture, education, food security, and so much more. Our unique seed scale methodology ensures that solutions are not only effective, but also locally driven and sustainable. Today, we are proud to celebrate our alumni, dedicated changemakers who are using what they've learned to uplift their communities, addressing pressing challenges, and inspiring others to do the same. This success sharing session is a platform to highlight their incredible work, share valuable insights, and foster connections across our global network. We are excited to have you join us as we learn from one of our outstanding alumni and explore how they've applied education to drive meaningful change worldwide. Today, I would like to go ahead and have, first I'm going to have Equo, our moderator, introduce herself. And then I'm going to have Adolphus introduce himself as then he goes ahead and transitions into his presentation today. Equo, please go ahead and share with us.
Okay, my name is Ikwo Oka, and I'm an alumni of the class of 2005. I've been working in public health, community health, actually, for a period spanning over 15 years. I've also worked in entrepreneurship development, but for a while, I've been looking at closing the gap of shortages in blood supply in communities. So I'm back to public health again, and also looking forward to also closing the gap in emergency preparedness in communities. So I currently serve as the Chief Program Officer of Trauma Care International Foundation, an organization that is into emergency preparedness, first aid trainings, and voluntary blood donation mobilization to ensure that communities are safe and resilient, and the local communities have appropriate knowledge of what to do in the event of an emergency. So that's what I'm currently doing, and I'm glad to be here as a moderator that I'll be taking the question and answer session. And thank you very much for joining us.
Thank you, Equo. Adolphus, could you go ahead and introduce yourself, and then I'll let you go ahead and start your presentation.
Thank you, Chris. Hi, hello, everyone. Happy Wellness Day to you wherever you are on this planet. It's good to be alive. It's good to be here. My name is Adolphus W. Dupley. I am the Executive Director for the Liberia United Methodist Development Services. It is the development arm of the United Methodist Church that is committed to providing basic social services for Liberians across the country. And I'm a 2015 alumni of the Future Generations University. I will now proceed with the presentation. As you see, my screen has been shared again. I'm the Executive Director of the Liberia United Methodist Development Services. And we want to focus today on community change, community health, that is also led by the community. And we are the implementing partner of the GC7 TB HIV Malaria Grant Cycle Grant in Liberia under Plan International as the principal recipient and LUMDS is the sub-recipient. Next slide, please. Today's journey will look at a few areas. We will be talking about who we are as an organization. We'll be looking at some challenges. We'll be looking at some community-led solutions. We'll be looking at some results. We'll be looking at some lessons learned, and then we go into a time of discussion so that together we can share about what we've heard, what we learned, and what we have experienced, and what we can take home together after the presentation. Next slide, please. So this is our brief history. As a development organization recognized by the government, we have started as a small organization or a small unit of the United Methodist Church. Our church, since the 1800s, has been in Liberia providing basic social services in education, healthcare, water, and sanitation. But after the war, based on the enormity of the challenges that the country had experienced, the church transitioned from church-based solutions to a nation-based solution. So we started what we call the Community Development Program in 2008, basically working with communities, ensuring that communities can leverage whatever resources they have to provide community-needed solutions. And so we transitioned into a department where we started to get more partners, delivering on more services and more organization support from other donors. And then we went now into full NGO status as a full functioning NGO in 2020 thereabout. So function now with larger partners, larger communities, and meeting larger needs. Today, after 16 years, we are still providing basic services, and we'll go into some of the areas that we worked and some of the impacts we have made. And we are functioning now in water and sanitation, education, healthcare, and basically within health, where our emphasis will be, we are into the community TB program. So that's us in a brief nutshell, from a small organization to now a full-blown NGO working across our country. Next slide, please. So in terms of what we've done over the years, as an organization that has delivered for Liberia, we've been working to meet needs and meeting needs where they are most needed in very sometimes out of reach communities long forgotten about. So over the last 16 years, we've worked with communities to help them, have standardized basic elementary schools, junior high and senior high schools, not just the physical structure, but we also work with the communities to ensure that the Parents Teachers Association, the community body responsible for education, can be empowered. They can have skill sets to ensure that the structure that both of us have worked together to erect can, experience learning outcomes. The PTA will ensure teachers are in classrooms. They will ensure they are monitored. They will ensure kids learn in safe spaces. So we've been able to deliver that with 30 basic schools that were existing before. We've been able to build the capacity of PTAs, the Parent Teacher Associations. We'll be able to train adults across the country in education-related services and skill sets. We'll be able to provide countless number of training for teachers as in-service teachers, and we'll be able to build teacher housing, because again, that is basic need for lots of schools in our country. There are schools in rural parts. The biggest challenge is they don't have access to teachers. And why? Because there isn't any place for teachers to live. So in terms of addressing that kind of need, we've been able to work with communities to ensure that when schools exist, then we help to erect physical structures where teachers can live to mitigate the challenge around the absence of teachers. So over the last years in our area of education, there are countless number of schools we built. I've shared the numbers with you. There are countless number of adults we've trained as Parents Teachers Association bodies with skill sets to ensure school function. Because again, it is a community need, it's a community-led, it's a community-managed solution that we work with over time. Next slide, please. And in area of health, which is one of the major areas we are still working in, but we've been practically delivering health services. What you see in the picture is one of the result of our health interventions with one of the community. And this happened around a tripartite relationship. LUMDS as an organization, at the time we were DCS, the community, and then the government collaborated and delivered this major health facility. It has a health catchment population of more than 30,000. Today, it is a referral, primary health care center delivering valuable more services than we earlier envisaged it to be. I mean, we worked with them and delivered that health center in the central western belt of our country. It's still a milestone today, but over and above across our country, we've been able to do clinics, construction, because we did a strategy where we do the physical, working with the community, with community support, the physical structure of the health facility, and then we empower the community members to ensure that those health facilities and structures that are built can function and deliver health outcomes. So we've been able to do major health facilities around the country. We have trained several nurses. We've equipped midwives in terms of meeting delivery needs for our people, where in some communities people will deliver on the hammock or in the bush or under the tree. Today, the stories have changed for those communities we work with, and then we'll be able to provide affordable health care for thousands of Liberians across the country. I must remind us again that this has been a community collaborative approach. And thanks to my stay with the Futures Generation, where we went deeper into bringing the three-way partnership, the outside in, the top down, and the bottom up. This has been the core of our function. We go along to talk about the method around which we operate somewhere down in the slides. Next slide, please. In terms of water and sanitation, which remains one of the major, challenges faced by our people across the country, LUMDS has also been able to work with communities to deliver vital water, safe water points for lots of communities across our country. We've done more than 300 water wells right across the geographical spectrum of our country, in many communities where since the creation of this country have not seen a clean water source. There were communities where access water and they will be, affected by diarrhea or the terrible waterborne diseases. And working with them, ensuring that we bring our different resources together, we deliver vital water, sources for them. We trained what we call the Community Watch Committee, because again, as a community-based organization, we place high premium on the role of the community that connects us with the valuable resources they have and what the government is already doing or supposed to do. Because again, water services, health services, and education services are for the government, as a responsibility. So we link all these three forces around solving these kinds of problems, and we'll be able to provide community institutional like trains for school to reduce open defecation. We provided like trains for communities where needed. Like community we able to improve community sanitation, basic things like coastline, insect crawling on it, basic things like keeping water solution that enhances people's health and water and sanitation services. We've also been an organization that invested and still believe in agriculture, the climate change, environment, and all of that. But we've also been working with communities around livelihood support. Here you see one of our investment in terms of working with the communities, because some of these things in all our work do not happen in isolation. It is not a kind of approach where we deliver for you services that you need and we think you need, then turn it over to you. Our work talked about need, what to do to the they can we leverage what they have and what expertise we have, working again, connecting with the government, in that three-way partnership to deliver the service. So communities have access to, cattle in ways and forms that they could donate, and support in, how they can tap up whatever resource they have to ensure we get the amount of cattle they need. Work with them, produce one or two, and they managed it to deliver more. This community was able to raise They sold the cattle and built houses themselves in our country, which say of the community, skill set, community resource that can be leveraged for their own good. So we've been helping to agriculture, husbandry. I'm back. Thank you. Chris, can you hear me? If you can hear me, let's go to the next slide. Sorry for the interruption.
We can hear you.
Hello? Thank you so very well. Thanks for your patience and understanding some of this technology.
No worries. No worries. We hear you now.
So again, into the way we work, we really put a lot of emphasis on communities, community capacity, community knowledge, skills, because we believe, and rightly so in our learning from few generations, there are lots of inherent capacities that reside within the community. There are lots of, positive, well-structured knowledge, you understand me, and they've done that, they've been working on themselves, doing solutions at their own level. What we do is just expand on those, knowledge areas. So we put a lot of emphasis on, human resource development. Here we're training PTAs, we're training development committee workers, we're training community water and sanitation committee. But this particular picture is only association training that is bringing all the different leaders in our school together. So when we do these kinds of invest, what we come away with is the possibility that these people are able to use the skill sets and knowledge they have to improve on whatever, project and deliver services for themselves, and which again, in a very useful and impactful way, sustain a long period of years that we've worked across different communities. Next slide, please. Okay, so as an organization, LUMDS has goals, we have mission, we have programs, and when I talked about how we work, we worked, on the basis set out to do. So our major goal is to provide comprehensive and sustainable social services to Liberians, no matter the tribe, the religion, the color, sex, or location. And it's important to remember because even though we are a church-based, denominational-based organization, we've set ourselves apart to ensure that we meet the needs of people. And the church has given us their approbation to do that because the needs has no tribe, needs has no religion, needs has no color, it has no sex. Where needs exist for water, is not talking about tribe and the rest of that. So we are a non-biased organization, and we've been able to reach out to Muslim communities, atheist communities, tribal, religious communities all across our country, because that's our goal. Sustainable social services means whatever there is that communities will need to ensure they thrive, they live well, they are healthy, they access education, healthcare, and the rest of that. Some of the programs around which we have been able to deliver these services are named on this slide. Currently, we are implementing a program called Save and Improve Learning in Schools. This is supported by the United Methodist Church of Norway, and the back donor is Digni. Digni is the government arm that works with religious related organizations supporting development across the world. And they support our work through the United Methodist Church of Norway as one of their member organizations. What Safe and Improved Learning in Schools intends to do is provide access to education for around 4,500 kids in one of our educational districts in central Liberia to ensure that they remain in school, they can progress to the next class, and they are safe in school, especially around gender-based violence. And it's one of the critical issues we've seen across our schools, and we'll talk more about that if time allows. Another program we implemented, like I said, when we started in 2008 with the community development program, is the community development program. That's how we started to now grow into an organization called LUMDS. Community development program practically suggests that we are helping communities to develop themselves in areas where they find needs that they need to meet. And we're talking about felt needs that the community has that they want to respond to. Those kinds of needs are communicated. We work with them, and they are the front line runner in terms of finding solutions to those needs. And then we also have the community integrated education program that lasted between 2010 and 2016. And what that program allowed us to do was to ensure that community looked at education from a holistic perspective. What is a school? What does school needs, both the internal and external factors? So we were working with communities around school structures, teachers' housing, teachers' availability, agriculture-related farm to support the school. And in many ways, we had some good success with that program, and today they are still functioning in many communities. Another program we also implemented was the Community Integrated Development and Need-Based Education Program. Mission Alliance is also another member organization of DIGNI, and it was Mission Alliance that supported these two programs I'm talking about. And then we also now have what we call Giving Hope to a Child. Giving Hope to a Child is a program that allows us to provide educational support for kids, pay some of the fees, because a lot of kids were orphaned by Ebola. Some are still with one parent, other parents can't afford. So we provide fees, book bags, school shoes. We provide other educational support to ensure that these kids remain in school. Giving Hope to a Child is also based in Norway with the same name and is comprised of philanthropists that intend to help kids in Liberia. And then we now working with the community TB notification since 2021 as a sub-recipient, trying to fill in the gap where the needs for TB must be met in terms of all of the barriers that we'll discuss further down that has inhibited people from accessing care and treatment, especially between the community and the facility, testing, follow-up, treatment. We are designed to fill in that gap and helping community members access vital TB care, which we've been able to deliver since we started in 2021. We have other smaller programs like the Child Representative Program, again, that caters to kids' needs around the country, and the Child Sponsorship Program, which is also like the Giving Hope, except that Giving Hope is sponsored by Giving Hope Norway, and Child Sponsorship is sponsored by UMC Norway. So this encapsulates the different programs we have and we worked with and we've been working with to deliver for more than 1 million Liberians. When we did our last external evaluation, it says we've served more than 1 million Liberians thus far over the last 16 years. Next slide. Our methodology, which we started to work on when I got enrolled in Future Generations University, it just broadened the scope because we have a methodology called Partnership in Development. Partnership in Development is no different from what we learned in Future Generations about the three-way partnership. Partnership in Development thrusts the change process in the hands of the community people. It is driven by the fact that community can identify the needs. They can identify some capacities that they have. They can link with other institutions and organizations, and they can connect with the government in ways and forms that ensure that when they're solving that need, it becomes a sustainable process. So partnership in development has been the method or methodology around which we work, where a community tells you, we have a need for water. We have a land where we assure or you can test if water can be produced if you dig. We have labor that can avail themselves to work with whatever expertise you have to dig the ground forward. We have human beings that can avail themselves to be trained to serve as watchdogs or people who will manage the water well. We have sand resources that we can gather that helps you to bring whatever you have, your understanding, to ensure the water well is available. And we can learn how to advocate with the government Ministry of Water or resources that will ensure that they will have constant follow-up. In our case, it's the Ministry of Public Works. We can advocate with the Ministry of Public Works to ensure that there will be constant follow-up. They will give us implements, they will supervise, and ensure this water well is sustained. What do you have? LUMDS? Well, we can help you with things you don't have. We can help you with resources that you might need to buy from the store that you do not have. So in that kind of connection, government as a top-down, community, and we as an outside in change agent collaborate around the need the community has. And even in the change process, the trust for the change is placed in the hands of the community. They develop the community leadership, they receive resources, they expend the resources, they mobilize themselves, they work for the project's outcome, they report to everybody involved, themselves, the stakeholders, the government, and they ensure the set of groups that will manage those projects completed once we have left. So this PID methodology was enhanced after we graduated from Future Generations and expanded to ensure that we can make more valuable use of community resident capacities that we can nurture to ensure that communities are able and empowered to bring change for themselves. And I can say to you without a shadow of a doubt that LUMDS has been one of the lead organizations pushing for community self-change, and the evidences are all across our country that we can point to visibly today. Next slide, please. Thank you. In terms of the community TB project, which we are working on as a sub-recipient under the Global Fund Round 7 support for TB, HIV, and malaria. The goal is to reduce the burden of the tuberculosis in our country and ensuring that there are equitable access, quality prevention, diagnosis and treatment, and care services while we try to integrate HIV, TB responses and strengthening community systems. So the TB project has several, angle around which the government is approaching. We are from the community TB angle. There's several cool goals around that is to strengthen TB case detection and treatment outcomes. We want to improve TB preventive therapy, TPT, and contact tracing outcomes. We want to promote human rights and gender equity. We want to enhance community engagement and ownership. These are several goals around this whole community TB approach that we will delve into as we go along in this discussion. And some of the strategic objectives, we want to expand community case detection. Again, like I said, the community case detection has been a gap. Many of the barriers we'll discuss later on is something that had inhibited people from accessing quality TB services. And we want to integrate the TB HIV services into the work that we do. So over and above, this has been our community TB approach, working together for preventing or limiting the barriers, pursuing our strategic objectives, and achieving our core goals for a country that has been bedeviled by the TB disease for many, many years. Next slide, please. So what is the community TB component that we are implementing, that we have been hired as a sub-recipient? Again, this was grounded on our rich history of community engagement and community work that really positioned us to, pursue this, successfully achieved this as our ship. So we are supposed to find, we're supposed to notify, we're supposed to connect, and we're supposed to save lives. So the notification actually refers to identifying and reporting people with suspected or confirmed tuberculosis within communities, rather than relying on the health facilities. All right. So some of the background is that the community case notification is especially important because many people face barriers to accessing health care. And that's very important to remember. Like I said in the beginning, there has been a gap between the community and the facilities. Facilities at the uh, primary level provide opportunity for testing, linkage to care, follow-up, and treatment. But because of some of the barriers, for example, distance, a lot of communities are not within the standard, what you call house to facility distance ratio. And some of the health experts can talk about that ratio, but there should be a standard time that each community should have, maybe 5 kilometer radius should have an access to health care. In our country, because of the geographical scope and the lack of infrastructure around the country in terms of healthcare, a lot of folks in distant communities are very distant from existing health facilities. Then there's another huge transportation cost because of distance, because of topography and difficult geography, bad roads, bad terrains. There are huge transportation costs. Many of our modes of transportation in our country today is basically using what we call the motorcycle, is a primary means of transportation, especially in most rural parts. And using that is hugely costly. Another, barrier has been stigma. TB is one of the most stigmatized disease in our country. A lot of people hearing about you with TB and knowing that you had TB, you are isolated, family shunned you, people avoid you. I mean, there's also gossip about you, and instead of having that family support that enable you to recover, you are pushed in, community areas where you most likely suffer severe consequences and die. Then there is limited awareness. There's not enough information at the community level where people understand around what the disease is, that it can be cured, that they can have access to treatment and all of that. And then there are other system challenges. Our healthcare system is riddled with a lot of challenges. That's enormous, that's overwhelming, that's bedeviled our system for many years. Thankfully, there are lots of effort to try to reduce it, but it still remains as bottlenecks today. So TB at the community level is designed to address these barriers. The community TB case notification brings healthcare closer to the people. Our job is to ensure that we leverage community presence, community knowledge, community experience, so that they can, within a community-driven way, have access to these services that are available around themselves. So we are able to find more cases, connect people to treatment more early, we can protect the community, and we can build health like you. So, that's what the community TB is about. These barriers to help access treatment and care for healthy living. Next slide, please, Grace. Let's have a picture of our health system in terms of basic areas. We have 3 tiers, and we have the primary care, we have a tertiary, so that allows services to get to the people wherever they are. You understand me? At the primary level, we have the community services, we have health facilities, we have promoting awareness, diagnosis. At the secondary, we have the outpatient, specified, we have treatment, we have higher diagnostic services, we have surgery and the rest. This is primarily how our health system is structured. And for community TB, we try to, for us as an organization, really look at the primary care where the community exists. Tuberculosis still remains a major challenge, in our country. There are lots of data, and you can see the information. Although progress has been made in expanding TB services and improving case notification, the burden of disease remains high with prevalent, gaps that are still being noticed today. So in terms of this challenge, we as a TB-related entity, we are trying to ensure that we increase notification. We trying to ensure we connect more people to testing opportunities. We're trying to ensure that we reduce the heavy burden of, you understand me, cost around transportation that allows them to access services. So we are focusing on detection, we are focusing on treatment outcomes, we are focusing on prevention, and we are focusing on financial protection. So these core values drives our work in the TB. The impact is that we want to reduce the burden and the prevalence. We want to ensure that more people access services. And we want to ensure that working again with the community, leveraging community support, community awareness, community strength, these people can work to ensure that they have services that helps them live from TB to healthy lifestyles. Next slide, please. So we want to look at the scope of the community TB work that we're doing. For example, we want to, first of all, reflect again on some of our national challenges. If you look at our health force challenge, in terms of health worker density, which again brings us back to the issue of barriers that affects people at the community level. I mean, for every 10, 1,000, person, the standard is there should be 23 health worker. But you can imagine, excuse me, please. You can imagine for Liberia, for every 10,000 health worker, there is for every 10,000, catchment citizen, there is only 12. So there's a gap of 11 missing health worker. That gap still exists today, and those stats, can be referenced. I'm sure the reference is out there. So these are some of the challenges folks are dealing with. There is a required number of skilled health workers that can be available at every population center in every town to ensure people access health care. So with those kinds of challenges, in terms of the scope, you can already understand what we are dealing with. Again, there is this urban-rural concentration. There's high concentration of healthcare in urban areas, of course, high concentration of healthcare workers in urban areas compared to rural communities. There's so much low concentration of health workers in rural communities. Not only there is low concentration, there's high iteration of health workers at the rural level. There's high migration of health workers from rural to urban. These are compounding problems that are, imposed upon communities. When you imagine communities living with absence of health worker, migration of health worker, absence of health facilities, they lay bare before lots of attacking forces, TB one of them, and they literally are almost helpless unless, again, like we have said, as a community-based organization, go in and help community realize that there are resident opportunities within themselves that we can leverage, and together we can access TB healthcare. That's what community TB is about. We worked with community health volunteers, create awareness at the community level, help people with presumptive signs and symptoms, access testing first of all, and if confirmed, access treatment. That's the scope of our work in the face of these challenges that we've just talked about. Next slide, please, Chris. So again, to talk more about the scope, you can see from this graph, which is from our national sector, our national strategic plan for TB 2027 to 25 years down the road, you see that tuberculosis in male is the second highest cause of death. In female is the highest cause of death. This remain alarming. And worse still, this death, majority of which occurred in rural communities where access to healthcare suffered all of the barriers that we've just enumerated in the previous slides, which presents huge demand that require that we have to step in and work with community to deal with. So TB is not just an ordinary thing, it's a major cause for death, a major cause for sickness, a major cause for disease. So you can imagine the urgency around, as we even think about World Awareness Day, what we are talking about and what we are doing with the disease in Liberia around the community component. Next slide, please. Yeah, we want to talk more about the scope, emphasizing some of the areas, how we are reaching communities and what we are doing. So the community TB overview grant is designed to target key population in community TB in high burden areas. You all right? And the program is implemented in 3 high burden counties. According to some of the records we have, TB is prevalent in Montserrado, Bong, and Nimba. TB is across all of our counties. There are 15 counties, but prevalence in terms of the rate at which more people are coming down with the disease. These are the 3 counties that were picked up with those high prevalent rates and counties that were identified where we could go in and work addressing all the key challenges that we talked about with the goal to end TB in Liberia. So, I mean, working with these communities, we have to go in and increase awareness around the TB disease. We do community notification. It means that we go in, talk to the community, help people understand what TB is. People avail themselves for testing if they present some of those signs and symptoms. And then we do what we call the sputum collection. Sputum collection is actually collecting the stuff that will help the laboratory folks know whether you have the disease or not. So it's something like a cough. It's collected in a cup secured process and transported to the lab and tested to know whether you are with the disease or not. And then we do contact tracing for every positive index case because TB could be, but it's a contagious disease depending on how you live with others. We do index case contact tracing. So everyone that is connected to the index case that's been tested positive, we trace and we connect and we treat you, and test you also for that so that we track and make sure we can, surround the disease without it spreading all around. And then we ensure that you have access to treatment. So we create the awareness, we do the notification, we collect the sputum, we test, and when positive, we put you on for treatment. And in these 3 counties, there are more details we talked about in the upcoming slides. We are focused on dealing with the barriers, stigmatization, discrimination, low cost to transport you for services. All these barriers we talked about, earlier on, are barriers we address in leveraging community support. And when I say community support, that means at the community level, we allow community to provide with us what we call community health volunteers that have been identified by the Ministry of Health already. And these community health volunteers are community members themselves. They work within 5-kilometer radius of where they live to ensure that they connect with other communities and other members to keep spreading the awareness, to keep looking for signs and symptoms, and encouraging community to reduce stigmatization and encourage people presenting signs and symptoms to get tested. And these community health volunteers also do follow-up. Once you're positive and you are tested positive for TB, then we have you get access to the drugs. The drugs is a 6-month regimen, treatment There are other shorter regimens that have been developed and being passed on now, but it has always been a 6-month regimen treatment that can be very rigorous. So if we don't have a follow-up, sometimes we have lost to follow up. We have people dropping off the treatment, and that can be a problem. So the community health volunteer play key roles. Again, we're talking about community-led, community managed, and community health. So we have been able to leverage every experience we have, every knowledge we have from future generations around the world to ensure that the community is at the center of this whole process around community TB. And we also do what we call co-infection. We're not specifically TB and HIV. There's another HIV-related SRO that focuses on HIV, but there's some things that we've come to find out that there's co-infection, people with TB also with HIV. In that case, we present those people for viral load testing, for counseling, and we are able to work and manage with our colleagues in the HIV SR to ensure that these people are cured both of the TB and the HIV. So whilst we are focused primarily on the TB, we also do some work with HIV where we come across folks that are co-infected with the disease. So we look for vulnerable populations, ghettos, areas where people are exposed, the prison, communities that cluster up together. In those kinds of communities in these 3 regions is where we really try to go and see whether we can find people with the signs and symptoms. Next slide, please, Grace. So yes, like I said, we do a co-infection working together because these 3 diseases are supported by the Global Fund, and it's important that we eradicate our war from them. So we are TB focused, but we also, work, where that connect comes in between the TB and the HIV. We also apply, our work with the HIV to ensure people have access to testing, to treatment and care towards being cured. So HIV also very prevalent in Liberia. Some of the stats are available online everywhere that you can see. Just like TB is also one of the diseases of what they call that is affecting people. So we also give priority to that. We are committed to close collaboration between the HIV and the TB programs to ensure that people affected by both the diseases are not left behind. Together, we save lives and build healthier communities. Again, that's our core function, working to ensure that people have access to treatment and care, whether you're HIV or TB patient. LUMDS roles and in this area, we ensure the HIV is tested. We link them to treatment. We ensure that they're treated for TB. We support allowance for follow-up, adherence to follow-up, and then we also coordinate with the HIV service provider to ensure that the folks, like I said, have access to both treatment and care towards being saved and healthy. Next slide, Chris. So more on community TB, which is our focus for today. We're talking about reaching communities. We've gone 6 years in the service now. We are working with community health volunteers. Like I said, these are folks that are recruited and are allowed to work within 5 kilometers of a community. They work because, again, they must have the confidence of the community members. They must most times be recommended by the communities themselves. They must have the trust of the people. So we leverage on that and make sure that we give them the skill sets that they need. We train them around TB notification, around TB signs and symptoms, awareness skills, advocacy skills, and we have them work with the communities, and they've been able to play some very key roles in helping us in the fight against TB in our country. We have right now around close to 200 volunteers that are working for the current program. I think it's 150 something. So it's a little over 150 current volunteers. We used to be around 200 plus, but then we were scaled down based on funding. 150 volunteers. They are working health facilities in several catchment communities means a community that are serviced by a big, do what we just started, create awareness. They talk, they look for signs, symptoms. They ensure you be positive with treatment resources. A hope is designed a way that application in confidential way. Sometimes community health focus in that process, but at least they help you access testing. And once you're positive, the health facility worked with the CHB in ways to ensure that you get on your treatment. They work with you on treatment follow up until you get killed. So these are real wonderful ambassadors that is making impact. They are closer to the communities, and we are working with them, and we are stronger together. We are promoting stronger community, stronger healthcare delivery system, helping communities to access healthcare against all of the barriers we talked about. So more on the scope and the work and the methodology. This is what we do currently in the TB work that we do in Liberia. Next slide, please. How is it designed? What's the model that we use? Again, we've spoken more about this. We'll just re-emphasize. The community health worker plays a very vital role as a frontline health worker, for all aspects of the disease in terms of prevention, in terms of fighting the disease. The CHBs are very, very vital. In fact, right now, the new policy refers to them as community health promoters and it's not volunteers anymore. And that policy has been validated. So I will interchangeably talk about CHB and CHPs. It will mean the same thing. They create awareness, they lead the community effort, sometimes during outbreaks like we had COVID-19, we had Ebola. Community health volunteers were very helpful in those kinds of areas. They facilitate treatment, they carry out follow-ups, they provide counseling services sometimes, they provide first aid services sometimes. We've trained them, they're not literally our staff, they are community members, but they work because we try to find some low transportation compensation for them, and we provide skill sets they need to effectively do the job. Whilst we are working with the CHBs, we also have what we call monitoring evaluation officers in our TB structured. We also have what we call the case notification officers. These are people who are health workers who manage case once identified at the community level. All these different people, the CHBs, the CHPs, our different structural staff along the chain, our central level program manager, M&E manager, work together in this design to deliver vital community services, TB services at the community level. So you see the designs are laid out there where people identify, create awareness, inform, report, you act, and then you ensure people are treated. And that model, it has a feedback loop because all along the chain, we are making sure we don't lose anyone. Because again, like I said, there are sometimes where we have lost to follow up because of the TB treatment regimen, because of other challenges. Sometimes in poverty, people have less access to food. TB is something that causes you to need one more healthy diet, more food, and when people don't have access to food care, they fall back on the treatment. So we have to keep that close loop of back and forth follow up along the chain to make sure we keep everybody intact towards treatment completion, and which we have been able to successfully see in different ways also. So that's the design of how the community TB model is structured, resident again at the community level. Next slide, Chris. So here is a photo of one of our health workers working around creating awareness. And this is how the CHPs we talked about are designed and structured in the 3 counties. So in Montserrado is our most populated county in what you call region in our country. So we're dealing with 7 health districts in Montserrado, and we're dealing with 79 community health promoters and 21 health facilities. This is designed in a way that the concentration of people, the prevalence, and everything. So you will see Montserrado has more of the CHPs that we talked about. In Bong County, we have 3 health districts that we are working with, out of 6, I think. And there are 35 community health promoters, and there are 16 facilities that we are working with. These facilities are within these communities, and we are with these CHPs connecting people to the health facilities for testing, treatment, follow-up, and the rest. In Nimba County, there are 6 health districts. We have 39 CHPs, and then we are working with 16 health facilities across the county. Nimba also is one of our most populated counties, geographically one of the largest counties, and with a very huge topography. It has some of our largest mountains, some of our reserve forest. Accessing communities can be very, very treacherous and demanding and overwhelming. But even in the face of all those very terribly difficult circumstances, we have community health promoters that are committed, resident within the community. Now, the standard says 5 kilometers is CHP. I tell you, on a daily basis, some of these CHPs are working within 10, 20, 15 kilometers, or in the name of ensuring that they remain committed to helping advance TB care and TB treatment in our country. Next slide, please. So this is the coverage, again, like I said, for the disease, in more detailed fashion. So in Montserrado County, these are the districts that we've named, and these facilities that are named. Diagnostics is one critical component when it comes to TB. What the policy says is that the first index testing for TB should be a gene expert machine, molecular testing machine. But because of in our country, I think we, like you see in the 3 counties, for example, in Montserrado County, which we are now on, let's talk about Montserrado. You see there are diagnostic centers, which means where TB gets tested, right? You see Clarendon, South to see they're using microscope. You see JFK, Catholic, Barbara, and Redemption, TB Annex, Badnersville, Health Center, and ELW. When you look at the health population of Liberia, the number of tests, Montserrado County is so huge, but in terms of gene expert, you have only functioning 3 centers. JFK, not 3, 6 centers that are using the gene expert, which is really, really limited. In other counties, there are only 2. So the policy say there only be first testing with a gene expert machine. But the reality is the availability of the machine is very, very limited. So we have to use a fallback with microscopic bacteriological testing to help with that deficiency. Gene expert, because the bacilli can be small, it cannot be detected by in some patients might be small. It cannot be detected by a microscope. And then the turnaround time for testing, a couple of hours for microscope is 2 to 4 hours gene expert. And then the microscope will not determine whether the TB is drug resistant. It's only the gene expert that can determine whether the TB is drug resistant. So that's why it's an international policy. Again, that is a challenge that we have to deal with because there's limitedness for the machines all across the country to be available for us to do the testing. So for Montserrado, that's the detail. The next slide, Grace. And then in Bong County, we've listed the health districts. We are working in some of the facilities that we are working in. And again, you can see for the machine I talked about, we have only 2 in an health population of more than 1,000 plus. And that is very highly, hugely insufficient to enable us to index case testing on first, test. Because you see, when you do the first test and establish the TB presence, then you can use the microscope for follow-up tests as you do the treatment. But we are constrained to use microscope because there are areas where it's just impossible, even though we're still struggling with the government policy that we stick to the gene aspect. Government herself is trying to ensure the availability of the machine all across the counties and country. We are dealing with that on a case-by-case basis where those are not available. We have to use alternative means and help the community get access to treatment and care. So for the number of community health promoters in Bong, we have 25 males and 10 females. Next slide, please. So for Nimba, again, 6 health districts, 16 health facilities. These are the diagnostic centers that I talked about. And again, we have 2 centers that are conducting the gene expert testing for TB, which again poses another challenge that I've just enumerated. And we have to find a balance because ultimately community folks will need treatment and care. And for the health promoters that we have in Nimba, we have 22 males and 17 females. I must say we a pro-gender organization. Sometimes we may not have a gender balance, but what we call affirmative action. We try in all of the things that we do to ensure that women have a space, they have a voice, they participate, and they play leadership role where possible, where necessary. We have a country that has been plagued by paternalistic women, a lot of we're still dealing with that in rural communities. So in our gender policy, we have a gender affirming role, and we insist on their participation and collaboration and leadership where and however necessary. Next slide, please, Chris. So that's what we've been able to do. We've been able to work at the community level in our work thus far. State of the country, state of the nation's address is the effect. He was able to highlight some of the success that the country has gained in TB notification, and which is a 7.6% increase in the TB notification in 2025, and is one of the highest level of the TB notification achieved, primarily for several factors. We cannot take the credit as a small organization, but we believe that our work at the community level, working with CHPs, vested with the community involved in herself, we contributed to that increase. And we are the only community-based TB organization in the country. So everything about community and what community is doing around key TB notification awareness, we believe that we have been able to play some role, ensuring that we meet people, ensuring that they get tested and treated and they can get cured. So that's a success, and we hope that we can build on that success, and we can, from evidence, expand on the success as one of those 2 pillars of the change process as we learn in future generations. Exposure opportunities they provided for us when we did our master's in applied community change. So that's what has happened. But more than that, community stigmatization has reduced, especially in communities where we have worked. More people now are keen to present themselves for testing without, being afraid. And, more people are accessing the testing and the treatment opportunities. Lives have been changed. There are early detection going on. We are referring and linking people to treatment quickly. We're trying to reduce the transmission as best as possible. We're promoting people to focus and, get to healthy households. There are better outcomes. More people are treated, more people are cured. And there's an increase in case notification. And that means that we can have more people getting access to test, cure, and being healthy again. You can talk about the numbers, but you can also talk about the human beings. And you can also talk about the value that this comes with, the value of the awareness that people realize that we can solve our own problems. We have the inherent capacities. We know where this is coming from. We can use ourselves and we can move forward. So that's the success about the change we talked about when we talked about community change, community health, and community led. It's about people working together, building trust, and achieving results. You see the nexus of the connection right there. The communities, they are agents of change, they participate in awareness, they reduce the stigma, they seek the testing and treatment, they support and look out for one another. LUMDS, we build the trust, we strengthen partnership, we support volunteers, we connect the community and health systems, and then we also do advocacy for quality TB services. The government, as a top down, they provide the diagnosis, the testing, they provide the treatment, they provide the follow-up care, they support the national TB response. These three connect at a nexus, which produces positive TB outcomes on the foundation of trust, engagement, support that equals to results. So we are happy about this model. We are happy about this connection. Iteratively, we've been applying ourselves to it, and we keep building on the success, and we keep focusing on the change and ensuring that we get to better TB outcomes for a healthier Liberia in the days and years to come. That's our foundation around community change. That's why it's important for community change. And when we think community change, we think community because community is vital for community change, grounded on community capacity. When communities are ready and they are engaged and they are involved, and we work together with a clear vision and shared responsibility, their inherent capacities, intentionally nurtured, can bring about lasting change. We have tested that. We've seen that work. We see it work in the TB. We see it work with our educational interventions. We've seen it work with our healthcare interventions. And we've seen tremendous success in intentionally nurturing inherent capacities in communities. It brings about leadership. It brings about trust. It brings about collaboration. It brings about problem solving. Of course, behavior change that leads to action, and action that nurtures local assets, that leads to sustainable community change, and of course, lasting impact for generations to come. How else can we talk about that than what the foundational studies and experiences we had at Future Generations that's practically seen and shown before us? On today's Wellness Day, we reflect on all that we've done and learned, and we keep sharing because we keep seeing these things lived out as true meaning in real world dilemmas. Capacity, readiness, engagement, participation, understanding, involvement, all leading to community capacity, plus shared vision, plus local action, leading to sustainable change. A wonderful testimony. And so, when we, no matter the task, no matter the objective for the change, we as LUMS, we have mastered the art of leading community change anchored on community involvement, fully linked with non-community outside-in agents that have continuously produced wonderful results. So what you see in this picture is a result of a community whose inherent capacities were intentionally nurtured that led to themselves rallying resources and constructing for themselves a school without a single dime from any outside, not even the government. Brilliant, wonderful example of what communities are capable of doing for themselves if you nurtured their inherent capacity by iteration, by shared learning, by building from success. These are results that we have seen. These are results we've seen with the community TV. These are results we've seen in our healthcare. And we are happy that based on everything we've learned and experienced, LUMDS as a community-based organization working with partners across the world can develop and work with community to deliver long-lasting, sustainable change anchored on outside in agents, top-down approaches, and the communities themselves that will continue to deliver real-life results and help grow a better world, deliver healthier communities, and ensure we achieve one health, one care, and one world that where all people can thrive and live healthier lives. That's about why community is vital for community to change. And that's what drives us in this work we do. Thank you. It's been wonderful sharing on this World Wellness Day. I hope we've shared enough. We can now have some questions and discussions. Thank you for your listening wherever you are. Thank you for your participation. We await some of your questions. Thank you.
Thank you, Adolphus. I'm going to go ahead and let you and Eco take this over. I would like just to remind everyone that you can drop a question in the chat, or you can place it in the Q&A area. And so, Eco, I'll let you go ahead and lead it.
Thank you. It's been a very outstanding presentation, brilliant. And we've heard so much about how the community capacity, shared vision, and local action has brought about sustainable change. Okay, a quick one. I have a question here from Chris Roper, and he says, "Thank you for an outstanding presentation today, Adolphus. Excellent work. I see that LUMDS is active primarily in 3 counties. With the great success that you saw last year, as the national government noticed that success, and are there plans to expand or copy the work LUMDS has done elsewhere in the country?" Adolphus, did you get that?
Yes, I did get the question. Thank you.
Yes.
Yes, Chris, I think the government has noticed the work. Currently, I am now in a government workshop where we are looking at collectively, all partners, we are now looking at specimen transportation, which is of the TB fight, specimen transportation. So the government has identified that unless all partners work together, the success must be in silos. So we have opportunities now where we are working together. The government is continuously creating different platforms where we keep bringing our shared knowledge, shared success, and ensuring that we work as a united body on the TB disease and prevention in our country.
Okay. Thank you for that. Chris, did you hear that? I hope it addressed your question. Maybe a little follow-up on that. I wanted to find out, I know TB often carries a lot of stigma around it. And I wanted to find out how the community health promoters or volunteers help build trust and reduce fear of stigmatization within the community.
Yes, thanks a lot. So, in our parlance, well, in our country, something is said like, what you do not know is older than you. I mean, like a parable or something like that. I think what has happened with our communities is lack of knowledge around what TB actually is, um, how people get treated, what are the consequences. I think a lot of myth existed around TB, so we were able to demystify, break down the myth, and help communities and CHPs understand the disease itself, what it is, what it is not, and why once with TB you should be able to avail yourself the opportunities for being treated and all of that. With those kinds of new information, breaking down the myth, it was able to build trust between the community health promoters and potential presumptive TB patients. And those skill sets around counseling, around confidentiality, around engaging around disease were things that we trained CHVs on how to, build. And using those skill sets and with the general knowledge we provided to the community, that trust had been developed. And so people are now openly willing to share more and talk more and avail themselves more. Because unlike what they knew before, they don't know that anymore based on the new information we provide.
Yeah, trust is very key, and
Right.
information is also very, very important.
Right.
Okay, I have another question here from Juliet Yamo. She says, great presentation. Looking back on your organization's journey, what key factor contributed most to your success? That's one. Then what lessons would you share with other organizations trying to create sustainable impact? So two questions
Thank
in
you.
one.
Yeah, I
What are the
can.
key factors that have contributed to your success? And what lessons would you like to share with other organizations trying to create same sustainable impact?
I think when we started to work as an organization in 2008 with this, what we call partnership development model, we literally went with the community in mind that whatever we want to do for the community must be led and managed and delivered by and with the communities. When we tested the model and found out that there are potential for success, even though really were lots of challenges which we built and improved upon over time, we believe that working with the community as the driving agent for community change is the most rewarding method you can use for sustainable development. I mean, a community that realizes what the needs are, a community that willingly expose themselves to learn about how they can solve that need, a community that avail themselves to work with you to solve the need, the community that present themselves to organize that even after you have left, they can use the knowledge and skill sets to manage whatever they've become. It's what motivates me every day. I go to some communities we left 10 years, I still see a water pump functioning because the water treatment committee they set up is working. May not be the same people, but it's being able to sustain itself iteratively. They change community actors around the water management committee, and the pump is still working. This year alone, we started to work in our sales project, and we went to the communities and said, listen, you are a public school, but there's limited resources from the government. What are you doing? Each of you is a farmer. What can you do to bring your existing, inherent capacities together for the school? One of the communities said, okay, you know what we will do? We're going to start a farm. They started a farm. They grew okra. Okra is a vegetable, and raised 600 United States dollars and paid all of the teachers that were not on government payroll. They today are expanding that farm to keep the school running for as long as the soil is there. And so that is my motivation, that there are inherent capacities within communities. We should just be intentional about nurturing them and ensuring that community can gravitate to the process where they realize they have the inherent capacity. They can receive the skill sets from you. They can be nurtured. They can be collaborated with, and together on their own, they can find their own solutions. That is sustainable development for me. And some of the things that contributed that is my experience with future generations. It's a wonderful design model. We had to go to Nepal, we went to India, we went to Rwanda. When we had gotten exposed to all of these different change processes around the world, I only came back to my country and said, listen, I've I've got a lot of knowledge, and we just pull it into our already community-based work we're doing. And that has driven us to where we are. And I think that model works sustainably, and it should work for many, many years to come.
Yeah. The unending source of energy that you have in the community remains a very important resource in the
Right.
work we do in communities.
Exactly.
It's there, it's unending, and if we can tap into it and build around it, we are sure to have outcomes. Thank you so much for that. Okay,
Okay.
just one more or two more questions here. How well, you've talked about it a bit. How has your experience at Future Generation University informed the way you approach community development? I know you've spoken about it. I just wanted to bring out some very important points there again. And then if you could leave participants with one lesson about the community change, what would that be?
You see, there are a
So
few
there are two
things.
questions here in one.
Yeah, I got it.
Asking you to look back again at your experience with future generations. I know you've mentioned it in some of the answers you were giving, but I just wanted to look at it and just pull out just
Yeah.
one or two very important lessons which you would also want to leave with at the end of this presentation. One key lesson that you want to leave connected to your experience with the future generations training.
Yeah, thanks a lot, Nicole. I appreciate the question. When before future generations, our community change was based on community action and LUMDS intervention. Okay? We didn't pay too much attention to the top down in the change process. They have the bottom up, the top down, and the outside in. Our concentration was more on the outside in and the bottom up, LUMDS and the community. Learning about the three-way partnership and some of the basic principles, iteration, learning from evidence, building on success. Those key principles, especially focusing on the top-down involvement in the change process that contributes to sustainability, was really helpful out of future generations. Paying attention to iteration. How will community continue to work even in failures, but we iteratively focus on doing something until it gets successful? Was informed by my experience with future generation. Thirdly, building from success. A lot of community has successful things. The recent example I just gave, communities members are farmers. Each is building a farm and supporting his home. And I asked them, if each of you can build a farm and support your home, what if all of you decide this energy we are building and succeeding with our individual families, we bring it together for the sake of the school? It was like you turn a light on and they said, listen, this is great. We never thought about this. And they went and produced $600. That kind of, you understand me, building from success, observing, noticing, investigating is something I got out of future generations. A lot more, but I think those are key ones that helped shape the way we work with our communities in the work we do with communities around our country. If you haven't been to Futures Generation, take advantage of it. It's a school model designed that presents a working development practitioner with a lots of global and contextual opportunities. You wouldn't regret that decision. So I encourage everyone listening to me, search out the school, pursue what they're doing now. They build on what we've done. When ECHO did it in 2005, we did a lot more when we got there in 2015, and they've done a lot more since I left. But if you're passionate also about community work, your passion must be driven by going for what exists in the community already. Not anything new, not anything different, and encourage communities to be the driver of their own change. Take that lesson with you in your community work or development work and see how it will thrive and how it will multiply and how it will become successful. I hope I've shared enough that others can pick up from. Thank you, Iko.
Thank you so much. And I can attest to that. I usually say every aspect and every sector I've worked in, whether it's public health or in entrepreneurship development with women and young people, I've often found those basic building blocks of seed scale as my foundation. And my outcomes are always result oriented. And at the end of it, what the joy you get out of it is that the community owns it, sustains it, and you can always come back and see what was started growing. And that has always been it with seed scale. Thank you so much, Adolphus. I'll hand over to Chris. Chris, I think I'll stop here. I think there's a seed scale chat on the chat box. I'll hand over to Chris. Thank you so much, Chris.
Thank you. I also wanted just to highlight verbally what Deborah, thank you. Before I move on, thank you, Adolphus, for presenting. Thank you, Equal, for moderating. And I want to say thank you to Deborah for doing the tech for today's session. I really enjoy working with all of you because I find it absolutely heartwarming to hear people that have graduated 10 and 20 years ago still talking about everything that they learned in a master's program like it was yesterday. So that in and of itself is amazing. So I just appreciate you both. And I wanted to go ahead and say that all of the questions and responses will be posted in the alumni Facebook group. So if you missed one, or if you have a question that you wanted to ask and you didn't have a chance to, go ahead and email me at chris.reiser@future.edu, and I will make sure to get it to Adolphus so that he can answer your question and we can get it out to you. And I would also like to go ahead and announce our next session, which is for International Peace Day in September 21st. And we will be having Gauri and Hari from Nepal presenting on the wildlife and human conflict. They both are Davis Peace Prize winners, and both of them have done projects focused on human and wildlife conflict in their respective communities. And so they will be doing a joint presentation for this next session. And so I hope to see you there. And I thank you again for coming and sharing with us today. It was a great presentation and just loved all the questions. So thank you again, everyone. And I hope you have a wonderful day.